Good afternoon, everybody. It's our pleasure to be here, coming from Seattle and meeting everybody. Today, we're going to talk about, you have been diagnosed with PKD, now what? This will be a joint session between me and Alethea, our nurse navigator. The objectives of learning today is explain the emotional impact of early stage ADPKD on patients, describe the nutritional needs and challenges for patients with ADPKD, and summarize steps to developing a healthcare team. This is meant to be sharing our approach, not a practice guideline, so just be mindful of that. On a way background, I serve as a director of Swedish Polycystic Kidney Disease Center of Excellence in Seattle. We care for more than 260 ADPKD patients. We do clinical and clinical research. We publish a few articles and book chapters related to PKD, and we continue to engage in the management of ADPKD. I am here joined by our nurse navigator, Alethea Ritchie. She's a nurse. She has been with nephrology for many years. She has been at the beginning of inception of the PKD Center. I consider her a cornerstone of our center. She is also the recipient of the PKD Foundation Navigation Grant. So we're happy to have her today. Disclosure as it's shown on the slides. So talking about PKD, this is a slide we put together, me and Ramperon, a while ago, looking at the disease progression in terms of the clinical perspective, so the clinical progression of the disease. As you know, the disease starts with subclinical. That means the disease is there, but there is no manifestation. This is silent disease. There is genetic mutation, but the silent disease. Patients might have concentrating capacity impairment. That means they feel early on they drink more water than their peers, especially early adulthood. But that's also soft, and not all the time it happens, but that might happen. But otherwise, it's a silent disease. As with the disease progress with age, you start having the early manifestation of the disease, maybe high blood pressure, maybe some cysts appear on the ultrasound or MRI. And in general, the kidney function is intact. Patients are not experience any symptoms related to the kidney size. As the cyst expand, which I always say, the disease is the cyst and the cyst is the disease, patients start to develop manifestation related to the disease, including back pain, flank pain, gross hematuria. And then they have a lot of patients at this level will have high blood pressure and decline in kidney function. As the disease progresses further, all these manifestations intensify and the kidney function unfortunately declines, leading to end-stage renal disease in early age, about 60% of patients with ADPKD. So understanding that this is a silent progression, initially silent disease, then progress is really important. One other aspect I really emphasize for the patients come with high blood pressure and they say, I do all the things. I have a low salt diet. I am active. My weight is good. How come I have high blood pressure? And it's just relieving for the patient to understand that this is unfortunately part of the disease mechanism. As the disease progresses, a lot of patients will develop hypertension just because of the pressure introduced by the cyst to the kidneys causing high blood pressure. So again, lifestyle modification is really important to control the disease, the high blood pressure, but at the same time, this is a part of the manifestation of the disease. So the biggest question when patient comes to the clinic or the center is understanding the disease trajectory. About 60% of patients will reach kidney failure before the age of 62, which we call rapid disease progression, patient at risk of rapid disease progression. We need to identify these patients because the treatment is different. If somebody is not going to progress to kidney failure, or if they progress to kidney failure, it's going to be at an advanced age, we're going to treat them differently. So you're going to be more aggressive for patients early on treatment, more aggressive for patients they are at risk of rapid disease progression. So we want to try to identify what risk factors patients have, put them at the category of risk of rapid disease progression. So the patients walk into the clinic, we ask them, who's in the family affected? Father, mother. What happened to the affected family member? Did they end up with kidney failure at early age? Although patients don't behave identical to their affected family member, there is a lot of similarity. There is a lot of information gained by understanding when the kidney failure happened and for that affected family member. What I call poor man genetic testing. So when is the family member affected led to kidney failure? Then if they have urological events, that means gross hematuria, blood in the urine that require ER visit, flank pain severe that require ER visits, cyst infection, pyelonephritis, infection of the kidneys. These are events that, the early onset on the disease trajectory, the more the poor prognosis, the more the likelihood that the patient will progress to kidney failure. Early hypertension, so that's the question also. When the patient are diagnosed with hypertension, the very next question is, what was the age in which the diagnosis happened? Because if patients develop hypertension before the age of 35, this is again an ominous sign that indicate that the progression will likely be rapid. If you have the luxury to have the genetic mutation, PKD1 truncating mutation is associated with poor outcome. However, we don't do this routinely in clinical practice. This is usually done in selected cases, but in general, PKD truncating 1 mutation is associated with poor outcome. If the eGFR declines more than 3 ml per minute per year over 5 years, this is the definition of rapid disease progression. However, I caution you, the goal from the patients and the physician is to try to identify rapid disease progression before the eGFR decline. Think of this. If you wait until the eGFR declines, this is like waiting until you have a manifestation of diabetes, like blindness or amputation to treat diabetes. We don't do that. We want to wait. We don't want to wait until the eGFR decline. And that's really a common pitfall in primary care physicians, a lot of nephrologists, a lot of patients. My kidneys are normal, so I don't need to do anything. But remember, the disease progresses well before the eGFR decline. So it's really important to try to put all of these together before the eGFR decline. And perhaps the single most important prognostic factor is how big the kidney cyst. So what we call total kidney volume, the combined volume of the right kidney and left kidney. And this is perhaps the single most important prognostic factor. How big is the cyst for this particular age? Because we categorize patients into the slow progression based on how big are the kidneys, or which is the total kidney volume. And since this is perhaps the most important prognostic factor, we're going to spend some time to how to navigate, how we obtain this one. This is obtained by MRI or CT scan. MRI and CT scan are equally sensitive and specific. Usually the model of total kidney volume does better after age of 18, a little bit after the age of 18 does better. In pediatric, the prognosis is not well established like in older individuals. So in general, in every patients who are with ADPKD, we want to establish the total kidney volume using an MRI or CT scan. So in terms of accuracy, CT and MRI are equally sensitive and specific. However, MRI does not have radiation exposure. So with CT scan exposure, there is long-term exposure and higher risk of cancer development. So we try to avoid this unless we really have to. So for example, we have a patient with cochlear implant that we have no option other than doing a CT scan. So we do one-time CT scan, we obtain the prognosis. But in general, for everybody else, we try to obtain MRI. Can this be the information obtained by ultrasound? The short answer is no. The ultrasound is not accurate, tend to underestimate. They are important in diagnosis, the ultrasound making the diagnosis. However, the prognosis is an MRI. So in our book, every patient who is with PKD at one point during their journey, they need to get prognosticated with MRI. Now, you don't have to have the MRI immediately at the beginning. You might have it within the course of treatment. However, this is an important piece of information that you need to obtain within the treatment journey. Now, I want to stop over here and talk about, the difficulties, the logistical difficulties obtaining MRI. And I'm going to turn this to Alethea. Alethea is helping our patients. So you come to the office, you explain to the patient the value of MRI, and then you put the order. So there is a lot of barriers that Alethea helped patient going through, and I'll leave the floor for Alethea to help with that.
Thanks, Dr. Amro. So usually when an MRI is ordered, I let the patient know like the process that is involved with the MRI and the barriers that can happen and how we address the barriers. And the importance of knowing if they're claustrophobic before getting an MRI, and the importance of it so we can arrange for open MRIs and prevent the patient from wanting to do the MRI because of certain barriers they have. And working with the insurance companies to make sure that their prior authorization gets done and approved so we can get it done. And occasionally when I have a patient that had an MRI outside of our facility in another state, and we had to get an addendum to his MRI. So I called the facility for the addendum, and because they didn't do the measurements for height, length, and width. And it was a little bit challenging trying to get the addendum done because their facility, the person that initially read the MRI, he was no longer there, so they couldn't get it addended. So we ended up having to order the CD to get the CD sent to the office. And I just kept the patient updated along the way, letting them know that this was unusual and it took a little extra time, but just keeping him updated so he was aware of the different challenges we were dealing with, and he wasn't forgotten. And eventually we got everything we needed. And I'm trying to think.
Yeah, I think the issue also with the claustrophobia, and you know, some patients has claustrophobia, and sometimes they don't feel comfortable telling the doctor they have, but they feel comfortable telling Alethea.
This is one of my the fun parts. So you'll tell the doctor so much, and then the nurse comes in and you get all the information. So I get to discuss it with him, and I was like, you know, this person's super claustrophobic. The open MRI is helpful, but sometimes still raises anxiety, and occasionally he will have to help prescribe a medication to help ease the anxiety and get the process done, and reassure them that it probably doesn't need to be done for another 5 years.
Very good. So I think explaining the process as Alethea is, and you know, identifying the barrier, and sometimes the barriers, as we discussed, a cost issue. So trying to get this authorized through the insurance is really important. A lot of patients want to do this toward the end of the year once they made their deductible. So there's like practical small things that's really helpful for the patient. But the bottom line is really helpful information for the physician at the beginning and perhaps as a follow-up. So this is really an important piece of information that, you know, with teaming with Alethea, and we'll be able to get the MRI throughout the process. Okay, and you know, once you get the MRI, that's the dimension that we really need, the length and depth and width. And that's what Alethea was talking about. Occasionally, if the MRI is done in a facility that they are not familiar with, why are you ordering the MRI? They end up with a report that does not include the information, that delays the care. So basically trying to, you know, proactive and get an MRI, if possible, in an institution that's familiar with reading the PKD, or if not, obtaining the CD will be the next step we do. And why this is important? Because of this, because we want to classify the rate of progression or the predicted rate of progression. So this is Mayo Clinic imaging classification for ADPKD, initially developed as a research tool, but now it's used as a clinical practice, perhaps with the most accurate method we have in prediction of the future. And I always tell the patient, this is a tool, I wish we have a crystal ball to tell the patients when the kidney will fail. We don't. We combine all the information together and we give them the best estimate. And I say, I always want the physician be wrong in the prediction. So if we predict the patient will end up with kidney failure 50, I'll be happy if the patient comes, see, I'm not in kidney failure at age 50. I would be happy to hear this, but we predict based on the available objective data. And the more data point throughout the journey, the more we'll be able to predict with more accuracy. So the patient's, this is the height adjusted total kidney volume. How big is the kidneys? This is the patient age at the time of the image. And the patient will fall into one of 5 categories: class 1A, slow progressor; class 1B, slow progressor, but a little bit faster. C and D and E, they are considered rapid disease progressor. Now, I want to go through 7 short cases to highlight each individual need that is variable. And it's really by the end of the session, you understand that disease is similar, but at the same time different. So I'll go through this, and me and Alethea will tag team on this. So this is a case one. This is addressing anxiety, anticipation, and family screening approach. This is a 28-year-old gentleman self-referred to PKD Center for Disease Screening due to family history of PKD. He's accompanied by his mother, who is a patient of ours. She is status post-kidney transplant at age 55. The transplant course was complicated by CMV infection and multiple opportunistic infection, really unfortunately bad course post-transplant. So you can sense the anxiety in the room. But I want to point out something that we learned the hard way. So this is a program we introduced, the self-referral for the family members. And why do we do that? Although we are a very specialized center, what used to happen is we tell the patients, if you have son or daughter, they want to be screened after the age of 18, go to your primary care physician, have them order an ultrasound. So they do that and they order ultrasound and they refer the patient. There is like a gap of 3 to 6 months until they see the physician. And during this gap, the patients really have anxiety. They feel anticipation. What do you anticipate? And even the ordering, what's the ultrasound results will carry? What does the implication of having a positive or a negative ultrasound? So a lot of unknown for the patient, creating anxiety. So we established this program, which is called self-referring. So if the patient have a family member and the family member want to screen, they simply come to us and we tell them, the pattern of inheritance. Believe it or not, not every patient know that this is an autosomal dominant disease. Now, every patient that they know that they have a 50% risk of developing the disease if they have father or mother, they have the disease. So we go over the very basic genetics, and then we go over about what is the current status of PKD treatment. What if you have the diagnosis, what will happen? And Alethea always say that although there might be similarity with the family, but everybody is different. I think I use her line a lot because patients will always, it can help other than patients will always say, I'm going to do like my father. I'm going to do like my mother. I'm going to go through the complication. You can't help it other than thinking of this, but really important to give them a hope, but not a false hope, but it's really a hope and a pathway. They know that, okay, regardless what's the results, and that's what we're going to get them before they leave for the ultrasound scheduling. Before they leave, regardless of the results, they know that they will be taken care of. They know they will be in a team that will take care of them. And anything to add on this?
Yes, I always ask especially in this situation when they come in with their parent and they've seen so much, like I always ask the patient, like, do you have any concerns? What are your biggest concerns, your biggest fears? What gives you the most anxiety? And try to, just address them and remind them that we're doing individualized care for each patient. And if they have questions, like it's a lot to digest on the initial appointment. So I always encourage people to reach out and remind them that I'm a touchstone to help address the anxiety, the issues, the fears they have, and give them the information they need to just address the disease in a more positive manner. Try to make it, so it's less of a canyon. It's more of a remind them of the advancements in medicine and different things that have changed, and that we have a good program that will watch them. So.
Very good. And I always point them to, resources that are reliable. Out there is a lot of resources about PKD. It's really important to direct patients to reliable sources so they don't get distracted with things that now may be scientifically solid. So PKD Foundation is really a good support group that I point the patient once they get the diagnosis so they feel they are supported. Onward for the case two. So this is a case about conservative approach. So this is a 50-year-old lady with ADPKD, has low cyst burden or low total kidney volume with myoclinic imaging classification 1A. That means these patients are unlikely to reach kidney failure, or if they reach kidney failure at advanced age. Again, any kidney failure is not good, even if it is at age 80. So the question is, how can we delay this more? This patient is appropriate for conservative treatment. That means, lifestyle modification, weight control if there is an overweight, and hypertension control. So she's overweight and hypertension, and that will be our focus for this particular patient. Their story is different, so this is going to be our focus. So the mainstay in the diet right now, we low osmolar diet, I mean low salt diet, and moderate protein restriction. There are some data to suggest alkaline diet, that mean leaning heavy more on the vegetables. I don't do any, exclusive diet. I think this is extreme. I do think that there is a general guide that the patient should follow. So what we call alkaline diet, that means moving toward more fruit and vegetables. And perhaps even without PKD, this is a good diet to follow. A diet that's full of carbohydrate and protein is not healthy, but leaning more toward vegetables and fruit, it might be benefit, in particular for PKD, based on some data from Kansas group. But again, it's just leaning toward healthy diet. And ketosis has been gaining some momentum. You probably heard about this. Intermittent fasting, I routinely encourage for my patients to do intermittent fasting, especially if they are heavy, if they are overweight, because data showed that the ability to lose weight with intermittent fasting might be easier. So this patient definitely, it might help with the kidney cyst progression with doing intermittent fasting, what I call 16 hours of fasting and 8 hours of allowed to eat. Again, there are limited data, but I think the benefit in multiple aspects is there. So patients will have an early dinner and then no calories until they have a late breakfast, and they have 16 hours of void of calories. I'll tell them do it twice a week. You can do it more or less, but this is in multiple studies in other than PKD showed it's beneficial for metabolism, and perhaps there is signal of improvement in PKD patients. And I'm gonna have Alethea take on low salt intake, because I think this is important, and weight control as well.
Yeah, so I get to come in after he overwhelms them. No, I'm just kidding. So I usually come in and offer information, handouts, resources to read about managing salt intake, the hidden sodium, the explanation again of why it's so important, breaking down any questions that they might have further that they want to discuss. They'll maybe ask me questions more than Dr. Amro. But just like really making sure that there's open communication. And if they stumble on something or have questions about any of this like salt, managing their salt intake or the diet, just making sure that they know that I'm a resource so I can help them get more information if they need it, or if they want more advanced information, and just trying to make the process easy on every patient that comes through.
Very good. And many times if our nutritional support, referral to nutritionists fail to help the patient who are overweight to lose weight, we utilize the help of weight loss services center, which is a spectrum that can go through nutrition, some medication, and for extreme cases bariatric surgery. But again, just trying to emphasize to the patient that managing the weight is an important aspect of managing ADPKD. And hypertension, early hypertension management, we know from the whole PKD that early hypertension, aggressive hypertension management is really important. And again, patients will be reluctant to start medication if their blood pressure high, because many of them are living healthy, but explaining to the patient that could be part of the disease, that will allow us to be much more in ease with taking a medication to control the disease. I always tell the patient, think of this as a disease, as a kidney medication, not only a blood pressure medication, if it's needed. Many times it's not needed, but if it is needed. Okay, so that brings us to the water. We talked about salt intake and diet as a mainstay. So how much water is needed for patients with PKD? And I'd love to hear your take in this. So how much water should we drink? And I think this is the question I always get all the time.
No pressure.
Yeah, no. Okay, so that's great to hear. I'm curious to know what 64 comes from. Mm.
64, no signs. Kidney cancer. You also have PKD.
Mm.
So part of the regimen that they put me on, put your protein and eat and drink a lot of fluids and exercise.
Very good. So you came up with a 64. That's very interesting. Interesting.
Well, for that, I would take you 128 hours. Part of it is with PKD, once you're introduced, is the issue that so many people have to go on the internet and they see it as a death sentence.
Yeah.
Especially when you're older. They say the average lifespan is 65. Here I am 66, and I have PKD. So I think that's part of
So this is really important to individualize the care based on what we know. But I love the prospect of 64, although it's a unique way to look at the number. Any other taker with the number? You can guess, you're not going to be wrong. Okay, so that's a good way to look at this. And so the number, you notice that there is no fixed number. And it bothered me as a fellow starting in a PKD clinic at Tufts that there is no number. I really needed to know that number. So this is a quote from the PKD Foundation. So how much water we drink is a function of culture, a function of habit. So if you are English, you drink tea not because you need the tea, but just because this is your habit. At the afternoon tea, this is your habit. If you raise children in which you put a glass of water with each meal, this is going to be their habit. Their physiological need is about 0.5 liters, so like 500 ml. That's your physiological need a day. Your average water intake in the United States is 1.1 liter. So again, this is emphasizing that then drinking how much water is a cultural and habit. So, okay. So if we know it's habit, we know it's important, okay, we need to know the number so we can change our habit to include this number, to reach this number. Very good. So we embarked on this trial, and we'll go through this very quickly. This is we published this in the American Journal of Kidney Disease, low osmolar diet and adjusted water intake for vasopressin. And the hypothesis there that the amount of water needed in PKD is not a fixed number. It depends on the diet, the salt intake, not it depends on what you eat. Simply placed, the more salt you take, the more protein, the more water you need to take. And that's what we shown in the study. I don't want to go into details, but this is really rigorous study to show that. But on average, for people, we measured what's the amount of water needed to suppress vasopressin, which is not good for the PKD. And it turned out for people who follow a low salt diet, moderate protein intake is 2.7 liter. So about 70 ounce. So you are well above this target. So again, the more protein intake, the more salt intake, the more water intake. So if your diet is good, 2.5 liter, 2.7 liter is a good target. If you consume a lot of protein, be prepared to suffer the consequences. So if you are into a salty meal, if you want to offset that, just drink a lot of water to offset the effect of the salt intake. Again, this is the concept we introduce, is the amount of water needed is a function of the salt intake and protein intake. Very good. Okay. So how much water, if somebody asks you how much water do I need to drink, you know the answer right now. It depends. We will come to this in a minute, okay? This is the physiological, right? You're always supposed to drink the water, but Genarco is a different perspective. I'll come to that. So for everybody with PKD, low salt diet, high water intake, and moderate protein intake. If somebody asks you how much water intake, it depends. If your salt intake is moderate, your protein intake is moderate, 2.7 liters based on the trial is sufficient. Obviously, if you drink more, it's even better, but that's the minimum for this one. Now, tolvaptan, will come to this in a second. Okay. Voila, we are the case 3, dietary changes and managed side effects of the tolvaptan. A 40-year-old gentleman with Mayo Clinic imaging classification 1E, very aggressive disease, was recently initiated on tolvaptan. He's having excessive thirst and frequent urination, interfering with his quality of life. The point I want to drive home is really important. What determined the amount of water needed for patient on tolvaptan intake? Again, salt and protein intake. So the more salt intake and protein intake, while on tolvaptan, you need more water to offset that. And this is not only theory. Gansvoort group in Denmark showed that this is actually what determined the amount of water needed in tolvaptan is salt intake. What's practically placed this is the more salt intake you do, the more side effects you get from the tolvaptan. Again, back to the basics. So I'll leave this Alethea to comment on this, how to help the patient navigate the side effects. But that's the connection. You have to establish this connection early on. The higher the salt, the worse the adverse event.
So initially, I usually start with the patients. When we start the initiation of the tolvaptan process, the sodium intake and the dietary adjustments are one of the things that I try to address right away. So they know what to expect. And they'll first, also like the first 1 to 2 weeks are probably the hardest on for the adjustment and the thirst and the having to use the restroom. And that if the side effects are so severe, you know, like we obviously try to make adjustments or offer different options of therapy. In this particular person, like we had to do some salt reduction, meal adjustment times, just to see if that would relieve the side effects and the interruption in his daily routine. So he did make some dietary adjustments and still had some hard side effects. And, you know, we just discussed them along the way and we ended up with an alternative for him. And just making sure that everyone knows, like, it's not something it's your choice, obviously, and just making adjustments to make it work for you is awesome. And if it doesn't happen, like, we're here to try to find another solution.
So the adjustment Alethea mentioned that really overlooked is, remember, one of the most common side effects is frequent urination. One of the bothersome part of the frequent urination at night. So this moving the meal earlier on the heavy meal earlier on the day helps a lot with the nocturia. So for example, if you are used to light lunch and heavy dinner and patients felt that the nocturia is a problem, moving the heavy meal earlier as a lunch and lighter dinner at night will help with the nocturia. So again, tying the salt intake and protein intake with the side effects is really important. Very good. So onward to case 4. This is a genetic counseling, emotional burden, patient and spouse. A 32-year-old gentleman with recent diagnosis of ADPKD has evidence of aggressive disease, myoclonic imaging classification 1D, abnormal EGFR, and poor outcome in affected family member. He's accompanied by his wife. The couple has no children, but would like to have children in the future. So this is highlighting the importance of having a family member support person involved early on in the decision. So you notice the anxiety. This is really important to educate the patient again about the pattern of inheritance, educate the spouse, which is really a important support person and involved in the decision over here. So this is really an important factor. And we discussed the option of having selective fertilization. Basically, we offer the genetic testing to work with the fertility clinic to reduce the chance of having children with a mutation. And I'll have Alethea's take on, talking to the spouse, because this is really an important thing. And having the spouse early on, having a contact person is really important.
So in this particular situation, we went in and both the husband and wife were actually well knowledge in what it was going to like for selective fertilization, the genetics, but they also needed some like extra, we had some question and answer and just really providing the support as a whole and the process with the genetic testing and the time that's involved and the burdens that they can feel on both, patient and spouse are thinking about having a family and giving them resources for support groups and the resources for the genetic counselors so they can get all their questions answered, and then assisting them along the way with any barriers that they have, because genetics testing used to be so expensive that you couldn't really do it, and making sure that like the world has changed a little bit and they've offered like better programs and making sure that they know that they have multiple different support systems and I offer to both, like all family members, like if they have a question, bring it up, ask me the question, if I don't have the answer, we're going to find the answer and try to help them along the process as best as possible.
Very good. And one take I say, we do not advocate for an approach or another. We actually simply educate the patient about the availability of the option. As you know, a lot of patients want to do a natural way of having children. So this is really important as providers. Our goal is to provide them with the available options. Don't push them either way. So, and anticipation, as Alethea said, if your patient doesn't know that the genetic testing will come every 4 weeks, they will be calling you every day to wait for the results. The genetic testing usually take 4 weeks and sometimes more. So it's really important anticipation. Also financial burden. They really need to know that there will be a financial burden with the selective fertilization. So just easing some of the anxiety for the patient with knowing what to anticipate, what options they have is really helpful for the patient. But again, this highlights what aspects of the disease that you don't think about. This is like having children really affecting the patients and the spouse, creating anxiety. Even if the patient has no symptoms whatsoever from PKD, there is still something there that's affecting them. And that's our approach. Okay, what else is important for the patient? I always use the line, I come to the patient and usually they are referred with other nephrologists or other primary care. And the first line I say, what are your concerns? And I always tell the story that not related to the PKD, that the patient's concern might not be consistent with your concern as a physician. So I remember one time a patient came to our clinic for a mild kidney disease. And I started with my usual line. I said, what are your concerns? I said, I want to walk. So, and it turned out that the patient had a back issue and a back abscess, and we admitted her to the hospital, totally new thing. So it is really listening. It is what gets you to the patient. And at the same story, what is the aspects of the disease that concerning the patient the most? Onward with case 5. This is a 40-year-old gentleman with ADPKD leading to advanced kidney disease. His current eGFR is 15. Now we are in different stage of the disease. This patient is reaching kidney failure. Their need is different. Their need is different. So we talk about the next step and then the options of transplant, dialysis, and access placement. And I think Alethea can walk us through the logistics of guiding this patient through this.
So this particular patient, I just went and reinforced the process of the transplant process and how it can be extensive and sometimes not always fast, but like I'm there to bridge if they have any difficulties and make sure that they are aware of the whole process. And if they have questions about the steps in the process, that they reach out. Because, you know, just more information eases the anxiety. And then make sure they have dialysis education early and why that's important. And then working with them for vascular access coordination. Sometimes it can be hard between the clinics, like getting coordinated. So I always say, if you don't hear in this a certain amount of time frame, like reach out to me, I'll reach out and then we can, you know, like especially with vascular and transplant, like sometimes there are certain barriers. And when you reach out nurse to nurse, just bridging between the different specialties is really helpful for our patients and getting them timely care and getting their transition and making it as easy as possible without stress, as much stress as there can be. And, you know, just making sure there's not a lot of barriers.
Just work as a liaison between, you know, crafting the plan and conducting the plan can be a totally different thing. Okay, I just want to briefly go into a few two cases. A 42-year-old gentleman with MRI showing small brain aneurysm 2 years ago. And as routine evaluation of PKD Center of Excellence, we look at the cases, we make sure everybody has a follow-up. And Alethea noticed that this patient has no follow-up. So this is a near miss that we learned from. And at the time of COVID, a lot of people lost a follow-up. A lot of people did not have the follow-up. So then we established this patient with the neurosurgeon, and Alethea really helped reduce the anxiety, what to anticipate. You know, a lot of patients said, I don't want to deal with this. I don't want somebody to have surgery for brain. They might not be aware that there is a minimally invasive procedure. They might be not aware that all of what is needed is just a confirmatory test or not. Fortunately, this patient We got them into a brain surgeon, our brain surgeon, neurosurgeon, and a confirmatory test that it shows that the aneurysm was an actually artifact. But so when they did the CT angio, which is more accurate testing, it turned out the patient has nothing. So it's really important that during this process, don't create unwanted anxiety, unneeded anxiety, but at the same time, walk the patient through this, the process. Okay, so we have, I'm gonna leave some time for the questions. I'll have this, another case of polycystic liver disease. This patient was having relatively mild kidney disease, but massive liver enlargement. And this patient's the options of treatment. We talked about octreotide, which Alethea helped administer the medication, and cyst aspiration. The cyst aspiration require help from another team member of the Polycystic Kidney Center, which is the intervention radiologist, specializing in removing the fluid without surgery, basically within the needle. Now, Alethea can talk a minute or two about the process of octreotide and
The process of octreotide can be a little complicated. It is an off-label treatment, but it has been shown to be effective for some patients. The side effects, I like to discuss the side effects and the process of the treatment. So this treatment actually involves injections in your muscle once a month, eat 2 injections once a month for 12 months. And I try to go through like the different side effects, and some people don't like needles, and I reassure them that I usually am the only one giving them injections. So we walk through all the worries and make sure that everything's, each person is different. And the different, like I've heard back from my patients, like some had diarrhea and some had, and these things can be concerning for the future patients. So just making sure that they're aware of the side effects and the process and what the injections involve and how the different outcomes come is really helpful. You build the trusting relationship and make sure you work with the insurance so they are not stuck with a heavy burden of the treatment.
Yeah, again, back to the same theme, knowing the process and, discuss the process with the patient early on. This is like, you notice the cyst is really big, and the patient ended up with cyst aspiration and octreotide, leading to some relief of the symptoms of the patient. Remember, octreotide is not for the kidney, it's for the livers, and it's for symptoms only. It does not change the outcome, but it's for symptoms control. So putting this all together before I take questions, you notice each aspect is unique, but you put this all together, you develop a comprehensive approach and a team building approach. So what I tell my colleagues is, when we have a need for transplant, having a transplant surgeon familiar with PKD is helpful. Able to take the kidney when the time of the transplant is needed is helpful. Able to remove both kidneys at the time of, if needed, at the time transplant is needed, is helpful. So having somebody who's familiar with PKD is really important. So having a team, a nutritionist, I cannot re-emphasize how much a nutritionist is important, again, for tolvaptan side effects and for patients with conservative treatment. And having somebody who helped with the prior authorization like Alethea, guiding the patient navigator is very important. And whenever you need help for extrarenal brain aneurysm, having a neurosurgery that's familiar with non-invasive technique is very important. You don't want to send the patient to somebody who's this their first patient. To see the PKD is really important. Intervention radiologist really equally important. We learned the hard way when I moved to Seattle from Boston 8 years ago. We referred, generally, I did not have a specification. And one patient ended up with the catheter broken in their body. They have to surgically remove the catheter because the patient who did the aspiration was not familiar with the process. And then we established the expertise. Then we realized this is our pathway. This is the person who's going to be expertise. And guess what? If somebody see patients all the time, PKD patients, they become expert with that. So that's the goal, that's the difference, is really to have a team who are invested on PKD patients. And with this, I conclude. I want to take, for the last 5 minutes, I'm going to take some questions. And thank you very much for listening. Yes.
So I have a question. I'm seeing in our clinic, seeing the number. So the genetic testing that you're talking about, fertility and stuff, so you can hold off like they were like 1D where you want to try to get treatment going. So is it, we're actually holding off because they want genetic testing.
So genetic testing should not change your management plan. That's correct. Just try to explain to the patient, like there are, for example, patients who even don't have MRI, but they have enough evidence to show that their disease is very aggressive, whether by ultrasound alone or by early decrease in EGFR. So you still can do all of that, but do not change the management. Once you establish as a clinician that this patient at risk of rapid disease progression, that's pathway you're gonna follow. And you can do the MRI in between, you can do the genetic testing, although the utilization of genetic testing, not a lot, because there is some variation between what you see in genetics and what actually happened. The ultimate manifestation of how big the kidney is on ultrasound or MRI. And if you have enough data to tell you that this patient has aggressive disease, that should sway your treatment. And this is a very good question. Go ahead.
So it sounds like from the presentation, you all have local and the nature of all the time to have handle maintaining.
So as you, so just to give you a perspective, we are Seattle, Washington. We are the only center of excellence in Washington State and the surrounding area. So we do say patients from outside the state. We do say, so we have, it depends on the need. So for example, if the patients come for a second opinion, whether tolvaptan is appropriate or not. So we do the evaluation, we do the thorough evaluation, we give the recommendation and go back to the general nephrologist with a plan. And we tell them you can check with us once a year for the development of a new research. Again, the follow-up is tailored to the need. So we still have patients from Alaska, they still want to come every year. We still have patients outside the state. At the time of COVID, in which we were able to see patients remotely outside Washington, we were able to do that. But now because of the licenses, this is restricted. But again, it depends on the need. So we do serve patients who are away, but it depends on the need. If their need, for example, to see what's the prognosis. So we do the thorough evaluation. We provide them with the best estimate of prognosis, send them back to the general nephrologist. And that's an opportunity to teach the patient and teach the nephrologist. Very good question. Yes, I'll take this and I'll come back to you. Go ahead. Correct. This is not approved for kidney disease. It does not help, unfortunately, although there are some signal at the initial trial, but it's not helpful. This is made, yeah.
I have 3 parts to my question. So I apologize.
No worries.
But do you recommend that young women avoid oral contraception? I feel like that is.
Fabulous question. Fabulous question. I cannot tell you how many times I feel very, very sad for patients who were on oral contraceptive pills for years and they ended up with massive liver because, you know, the patient, the primary care, the gynecologists are not aware that extra sources of estrogen is associated. The liver cyst is sensitive to estrogen. So it's really important to avoid exposure to estrogen from outside. This is a really important point. And you have a third part to your question.
Yeah, I just feel like so many people don't know that.
Beautiful, beautiful point.
And we talked about that, and I would have had no idea having a young daughter that just because with PKD, there was other manifestations that she was having things when she started period really heavy. So the first thing they went to was, oh, let's get you right on contraceptives. So having not known that, she's been taking contraceptives just to control
this.
So, and then my last bit is, I'm sure you're aware of the study where it really added the treatment to the outcome of that. So any comments on that?
So the short sweet is octreotide is for symptoms control on liver so far. It has a lot of hustle, as Alethea was saying. So selective patients, again, this is not, unfortunately, a kidney disease treatment. This is a treatment for, it's an option that's really good for patients, but it's mainly for the liver for symptoms control. Did we have a, yes?
I have in Los Angeles is so many primary care physicians don't treat, refer you over to a PKD specialist.
Yeah.
I think that is a real shame.
There is a knowledge gap. And I think, you know, patients having knowledge is really important. That's really a driving force. And nephrologist having knowledge, and primary care physician. But I think your point is well taken. This is really important that, okay, don't wait for the EGFR, because we are so used to the EGFR kidney function as a manifestation of disease. Oh, you're good. Once your kidney function start to fail, I'll send you. But guess what? I can't do much for you. When I see you at EGFR 15, when you are toward the end of the treatment. So early referral is really key. And for the sake of time, we have to conclude. But I really appreciate your attention. Sorry, I'll take a last call. Yeah. So the answer is clusters in family. It clusters in family. So the risk is associated with the question to stratify the risk, whether there is a family history of brain aneurysm or not. If there is a family history of brain aneurysm, the risk is as high as 5%. If there is no family history of brain aneurysm, the risk is as low as 1 to 3%. So if that will give you a specific answer to your question. So the more, if there is a family history, the risk is higher. If there is none, there is still risk, but low. But with this, we conclude, and thank you very much for attending, and I'm happy to take question after the